A very good evening to all the respected dignitaries, seniors, colleagues, experts, speakers, and all the attendees who have joined us through Zoom as well as YouTube Live. Welcome you all on behalf of Maharashtra Academy of Pediatrics and MahaIP Women's Committee for today's program of Tuesday Tea. This is a unique program which was designed and started from the month of Feb by Women's Committee Chairperson and Co-Chairperson. Up till now, we have done 10 Tuesday takes and today being the 11th episode. We have 11 speakers from different zones of Maharashtra allotted with 6 different topics, 5 minutes for each speaker to present, and we have 2 experts for guidance who will give their expert opinion after each topic. Please note today's program has been allotted 2 MMC points. So requesting everyone to please type your name, city name, central IIP and MMC credit number in the chat box. Dr. Shirish Dattare Deshpande sir, senior physician from Nasik, is the MMC observer for today's program. I, Dr. Neha Singh, MahaIP editor and practicing pediatrician from Navi Mumbai, as well as my co-host Dr. Reena Rathi ma'am, co-coordinator and zonal coordinator of MahaIP Women's Committee for North Maharashtra are the moderators for today's Tuesday tea. Now I hand over to Reena ma'am for further proceeding. Over to you, ma'am.
Thank you, Neha. Thank you very much. Good evening, one and all. I, Dr. Reena Rathi from Nasik, have privilege to welcome our President, Dr. Hemant Gangulia sir, our Secretary, Dr. Amol Pawar sir, Chairperson, MahaIP Women's Wing, Dr. Renu ma'am, Co-Chairperson, MahaIP Women's Wing, Dr. Sonali Shirpate ma'am from Amravati. I welcome you all along with my audience and all the speakers and respected judges. As Neha already mentioned, this is this year's last Tuesday talk, that is 11th one. And we have got a huge response for this Tuesday talk. I will request our President Hemant sir to have a few lines about this. Over to you, sir. Thank you.
Thank you, Dr. Reena. Good evening and respected judges for today's session, Dr. Mahesh Mohite sir, Dr. Prashant Jadhav sir, as well as all the 6 speakers, 6 presenters, Dr. Prama madam, Dr. Madhura madam, Dr. Grivita madam, Dr. Monish, Dr. Parishit, as well as Dr. Munjambi, and the moderators, Dr. Reena and Dr. Neha. As well, at the outset, I would like to thank MahaIP Women Committee Chairperson, Dr. Renu Madam, as well as Co-Chairperson, Dr. Sonali, to carry out this all 11. Today is the 11th episode of the Tuesday Takes. All 11 episodes successfully, and all 10 zonal members of 5 zones of Maharashtra to take the interest and to give the one speaker from each zone every time. And because there were 6 speakers, we had at each time 2 speakers from one of the zones as decided by this committee. So thank you very much all this MahaIP Women Committee to do this wonderful work of this Tuesday Takes. Concept was that in 5 minutes we get one topic. The message is take-home message clear cut, because nowadays our attention is decreasing. So within 5 minutes, what one can give the take-home message, that was the concept. And this concept well taken, and all the episodes were huge successful. And let us hope this episode will be also successful one. And this is the last episode of this year, 2022. As well as I welcome all the viewers on the Zoom dais, as well as on the MahaIP YouTube channel to see these episodes. And I'm sure this last episode of this year will be also a huge success. Thank you very much.
Thank you, sir. Thank you for your very kind and encouraging words. Now I'll request our secretary, Dr. Amal Pawar sir, to have a few lines about it. Over to you, sir.
Thank you, Reena. Good evening and welcome, my dear friends and guru, today's experts, Dr. Mahesh Mohite sir from Panvel and Dr. Prashant Jadhav sir from. I'm audible?
Yes.
And Dr. Prashant Jadhav sir from Aurangabad. He is a past executive body member and he is one-stop solution in Central IIP during last 3-4 years. So this was very nice concept put forth by Dr. Renu Koralkar ma'am and ably supported by President sir, myself and Dr. Sonali ma'am, and also next year co-chairperson, Dr. Neha Singh, and all the patrons and all zonal members of all the 5 zone women committee, Maha-IP women committee members. They have taken a lot of efforts in giving the names of all the speakers by contacting the office bearers, president, secretary, treasurers of all the 43 branches of Maharashtra IIP. And this program has got huge response, be it this 2 MMC credit points, which we are giving free to all Maha IIP members, those who are life members of Central IIP. We are giving 2 free credit points because of that, and also the interesting topics and interesting speakers from all over the zones. Almost all the programs have got more than 500 viewers each time. Means this is today's 11th and Zoom is full, and on YouTube also I'm seeing almost more than 300 people have already joined. So I thank all office bearers of entire Maharashtra IIP branches, Dr. Renu ma'am and Dr. Sonali ma'am, Neha, for guiding us in this continuing this program throughout the year. I again give all the best to all speakers of today's program, and we'll be continuing this program under the chairmanship of Dr. Sonali Shirbate ma'am next year, and she will be ably supported by Dr. Neha Singh next year also. Thank you. Over to you, Reena ma'am.
Thank you very much, Amol sir, for your very kind words and also for the 2 MMC credit points. I will request our chairperson, Maharashtra IIP Women's Wing, Dr. Renu ma'am, to have few lines over it. Over to you, ma'am.
Yeah. Good evening, one and all, and also the respected President and Secretary of Maha IIP, as well as today's judges, Dr. Mohite sir and Dr. Prashant Jadhav. It is a great pleasure to have a journey in this bullet train, which has started in February 2022, and now it has reached the final destination today in December 2022. And we know that the focus on the journey is not important, but it is the focus on the journey is more important rather than the destination. Also, we know that the joy is found not in finishing any activity, but in doing this activity, which we Women's Committee, along with all our Women's Committee members, the zonal coordinators, as well as the editor, Dr. Neha Singh, Dr. Vishal Raut, our digital wizard, along with Pallavi ma'am, who is the digital support, and with all the president and secretary guidance and the OBEB's guidance of Maharashtra, we could have the 66 new delegates to have speakers for first time on this platform for Maharashtra state. And also they could do it successfully. And we are very much happy to have them in our team and in this train, which will again take over next January 2023 in the form of new passengers as well as new drivers and conductors. So best wishes to all the our today's speakers, as well as I congratulate each one of the team workers who were there with us throughout this journey. Thank you one and all.
Thank you very much, ma'am, for finding out the talent from all over the Maharashtra. And that too remarkable, you are not repeating a single speaker, and all are young and presenting to the Maharashtra for the first time on the platform. Thank you very much, ma'am. Now I will request Sonali ma'am, if she is around, to have few lines or your opinion on it.
Thanks, Reena madam. Thank you for your kind words, and I think we should proceed now for the Tuesday text. Thank you very much. And excellent speaker you had selected, and you have been working very hard for this. Let us move further. Thank you.
Thank you very much, ma'am, and all the best for your new responsibility for the next year.
Thank you.
With that, I would like to welcome our judges. Dr. Neha will introduce our judges. Yes, sir.
Dr. Neha, madam, please.
Yes.
Excuse me. Because this is the last episode, and from the next episode, the themes will be changing. I would like to thank Dr. Neha Singh as well as Dr. Vishal Raut and Madam Pallavi to the excellent work throughout the years. Excellent flyers made by Dr. Vishal Raut, as well excellent messaging done by Dr. Neha and Pallavi, Madam, to all the technical supports. I'm really indebted to all of three for this wonderful journey of this episode throughout the in all other events too. With that, I will just take the opportunity, Dr. Veena Madam, if you don't mind, I would like to my left hand state convener, Dr. Jay Kumar, also to speak something, and then we will proceed with the things. Okay.
Sure, sir. It's our privilege to have Jai sir on the dais. I welcome Dr. Jai sir and
Thank you.
request him to have few lines. Over to you,
Yes.
sir.
I will continue the all sentence of Dr. Sonali Siribate. I think we should continue this because a lot of viewers are there. This is a very beautiful way of presenting the content. I will say rather it gives the glimpses or stimulus to the audience so that they can go back to book and journals and may googling it and read details about that the subject discussed in this topic. So thank you all the women committee for taking this wonderful session and going to be continuing next year also. Thank you very much for giving the opportunity to talk in front of you. I just enjoyed the last 2-3 days the Jalgaon sports, all this everybody's in the all photos and everything videos on this our WhatsApp group. Thank you very much. All the best. Let us continue our this academic session first.
Thank you.
Thank
Thank you
Reena,
very
1
much,
minute,
sir.
Reena. Reena,
And
1 minute.
congratulations to you for winning. Yeah, Amol, you're about to say the same thing. Please go ahead.
He won many awards at sport conference, but I welcome now officially to Dr. Sirish Deshpande sir, who is senior physician from Nasik. He is there. He is busy. He has just joined, and he is MMC observer for today's session. So it's request to all delegates, don't leave because you may lose 2 points. Thank you.
Thank you, Dr. Amol, for your valuable and important instructions. I welcome Shirish Deshpande sir, and really he is a very down-to-earth person and gem of the Nasik. With that, to welcome our judges, I request Dr. Neha to continue further. Over to you, Neha. Thank you.
Yes, Reena ma'am. Our first expert for today is Dr. Mahesh Amrut Mohite sir. He is consultant pediatrician and neonatal intensivist at New Panvel as well as at BJ Wadia Children's Hospital, Mumbai. Sir is great teacher. In fact, my mentor too. Sir is council member of Pediatric Critical Care India. Also, chairperson of IIP Intensive Care Chapter 2022. Sir has received Dr. P.M. Udani Oration Mahapedicon 2021 and Dr. Sanjeev Rai endorsement lecture at Car Pedicon 2022. Our second expert for today is Dr. Prashant Jadhav sir. Sir was executive member of Central IIP 2020-21, Maha IIP EB 2013 till 2017, organizing president for Maha Pedicon 2016, president and secretary of IIP Aurangabad, CPS council member and PG teacher, vice president CPS Mumbai. He is also director of Sanjeevani Children's Hospital, Aurangabad. I welcome both our experts of today and will request them to please give their best wishes to the speakers. Over to you, Mohite sir.
Thank you very much, Neha. I think this is a wonderful concept in all. आपण ते समुद्र मंथन वगैरे ऐकलेलं आहे की you just churn out everything and get the cream of it. I think we are going to get cream. I heard there are 66 faculty involved, and these are all who we have not seen in the regular dais, but at the same time we realize that there's so much of talent. So India's Got Talent, Maharashtra's Got Talent show is going on, and it's a very important, though it's very short opportunity, 5 minutes. I understand it's very difficult to cover the topic which is given, and most of the topics, I don't know, when I saw my hyperthyroidism case, maybe I've seen about 4 cases in the last 30 years. But again, that gave me an opportunity to at least read a bit on that. So thank you very much for giving me this opportunity to be a mentor. I've spoken to all 3 of my the candidate given to me, and I'm sure they will perform very well. Thank you very much again, Maharashtra IIP, for giving us this opportunity. Thank you very much.
Thank you, Mohite sir. Now I would request Dr. Prashant sir to kindly unmute.
Thank you for making me part of this activity, and very great to know about all the concepts, the way it has been brought forward. excellent ideas by the office bearers, Dr. Renu, Dr. Amol, Dr. Gangulia sir, and I'm very happy to be part of it, and had a interaction with three nice young speakers who are going to speak today. And definitely I know they are going to rock on the speech that has been provided by the woman wing. All the best to all the 6 speakers who are going to speak today. And I know we are going to come out with the excellent talent in front of all national IIP through this course over a period of time. So best of luck.
Thank you, Prashant sir. Reena ma'am, we can start.
Yes, thank you very much, Neha. With that, I welcome our first speaker, Dr. Prama Bafna from Kolhapur. She is going to talk on post-measles complication. Dr. Prama, over to you.
Yes, ma'am. Thank you, ma'am. Is this good? Am I audible, ma'am?
Go ahead.
Yes.
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 Okay. Okay, as we can see on the screen, this is the reason why this topic was chosen as a part of the symposium today. And I would just like to highlight that India is the world capital today in measles and measles death in the year 2021 and 22.
You double tap the cursor on the screen. Double tap.
Okay, yeah. As we can see here, it is 11,055 cases just in India. So, good evening, everybody. I'm Dr. Prama Bafna. I'm practicing in Kolhapur as a pediatrician and neonatologist. And I will not take too much of your time because I don't have too much of it. Measles suppresses the immune system for almost weeks to months after the infection. And as we can see, morbidity and mortality is the highest in lower age group, especially less than 2 years of age. Those with severe malnutrition in the form of either kwashiorkor, marasmus, or any other form of malnutrition, immunocompromised, especially those with HIV, those with any blood cancers, and pregnant women. Measles lower serum retinol levels, and those with subclinical hyporetinolemia might become clinical, hence the association between measles and vitamin A. So respiratory complications, as we know, of measles have been the most important one in the past, and even today they are the only ones which trouble us. So acute otitis media is the most common complication, though the most dreaded one is pneumonia. And pneumonia can either be direct due to the virus itself, or it can be a secondary or superimposed infection. Common organisms like Streptococcus pneumoniae, Staph aureus, Haemophilus influenza were seen in the past, but because of use of immunizations, proper vaccination schedules, these are not commonly seen. In immunocompromised patients, if a patient develops measles followed by pneumonia and it progresses to bronchiolitis obliterans, then it is almost always fatal. Now, this is a special topic, measles and tuberculosis, which is of interest, especially because measles may exacerbate the underlying mycobacterium infection, and a patient may suffer with TB just post-measles. Also, there might be a loss of hypersensitivity, which is a delayed type hypersensitivity reaction to the Mantoux test. So we might miss some cases of TB. There might be a reactivation of BCG scar, which looks like this, which is also seen sometimes in Kawasaki disease. However, this is not a dreaded complication because it can be managed with just supportive care and vitamin A supplementation. Coming to neurological complications, it can range from a simple febrile seizure to encephalitis to the most dreaded one, that is subacute sclerosing panencephalitis. Now, encephalitis presents differently in immunocompetent and immunocompromised individuals. In immunocompetent, it is mainly immunologically mediated and will present with seizures followed by lethargy or coma. And the mortality is not very high, but still it is 15%. Compared to that, in immunocompromised, the virus itself damages the brain cells, and it will present 1 to 10 months after measles with seizures, myoclonus, stupor. This is always fatal. In any immunocompromised patient, if there is encephalitis due to measles, it is fatal. Now, coming to subacute sclerosing panencephalitis, which is actually a complication of yesteryears. I have just come across one case during my UG days, so almost 12 years back. It's also known as Dawson's disease. It's chronic, progressive, and fatal. It's self-explanatory in the definition itself. But what we have to keep in mind currently, why this is important is because if recently we have come across patients with measles less than 2 years of age or even less than 4 years of age, we better maintain a proper record of it, maybe even a national surveillance record, because they might have a tendency to progress to SSPE at around 9 to 13 years of their age. And there is absolutely no cure for SSPE, though there are some trials in the form of antivirals like isoprinosine, ribavirin, immunomodulatory drugs. They might halt the progression of the disease, but it will any patient will eventually succumb to it within 1 to 3 years of onset. The only way to prevent SSPE is with proper immunization. There was some UN cry about this being caused by measles vaccine virus, but till date, it has not been reported that the vaccine virus causes SSPE. It is always a defective or resistant virus. Just to complete the list, croup, laryngitis, tracheitis, bronchitis were seen in the past. There was an entity called hemorrhagic measles or black measles. Then there was myocarditis, keratitis, which were seen more in the past due to malnourished children. We, I'm sure, have not come across many cases of post-measles complications, at least in the last decade. Because
sorry to interrupt you. It's already 6 minutes. Kindly
okay,
be fast.
ma'am, I'm done. This is the last slide.
Thank you.
Measles during pregnancy can lead to high maternal morbidity and also stillbirths. I hope this did not happen today because it was a very short presentation. Thank you.
Dr. Prama, thank you for your excellent and rapid presentation. Over to Dr. Mohite, sir.
Yeah, how much time do I have for a comment?
Sir, 2 minutes.
2 or 3 minutes. Fine, fine. Just quick comments. First of all, the focus of today, measles virus come up. Perhaps in between, we are hardly seeing any cases. And suddenly there is upsurge. And post-COVID, we are worried about any viral epidemic, this being one of them. In our days, in a PG and all, we used to see literally thousands of cases. And really, it was a routine, common, acceptable disease. Now, when you suspect in complication, commonly, commonest infections are, the complication are the infection, bacterial superadded infection. That is because of transient suppression of immunity. And nowadays, how do you suspect it? We have typical course of measles. We got fever, and fever will sort of progress. On 3rd or 4th day, the rash will start from head and go to the toe. On 7th day, the fever subsides. And with that, the rash also will sort of reach the feet. So if the fever goes beyond 7th day, you start suspecting infection. That's the first common kind of a signature. So on 8th or 9th day, the fever continues. Cough is always there, so that don't hint towards a respiratory bacterial infection. But fever further becoming toxic after 8th or 9th day, will start complicating. Epiglottis is one of the complications, but nowadays because of good, nice H-flu vaccine, that being the commonest cause, H-flu, which causes epiglottitis, which is no more seen nowadays. SSP, what doctor already said, 1 in 1 lakh complication. We have seen about 8 or 10 cases in our lifetime. So I'm sure in retrospect you can track. One common problem that we see is misdiagnosis of measles. In retrospect, it comes from the patient as well as from practitioner. We will say there was fever and rash and mislabeled measles by the patient as well as by the doctors also. So that kind of category has to be segregated from the pool of cases that we are reporting to us. So I think overall it was a wonderful presentation. Thank you very much for revisiting us measles. I think you have covered almost everything. Treatment-wise, there is nothing, just supportive line of treatment. During the peak of the period, some patient may require hospitalization, especially immunocompromised patient may require. And vitamin A, for whatever said and done, is the only thing maybe you can use as placebo if at all, but use it so patient feels better. Thank you very much.
Thank you. Thank you very much, sir, for your excellent and rapid guidance and comments. Thank you, Dr. Prama. I would like to introduce and welcome our next speaker, Dr. Madhura Rajam from Aurangabad. She is going to talk on thyrotoxicosis in children. Over to you, Dr. Madhura.
Thank you, ma'am. Good evening, everyone, and I'm very grateful for giving me this opportunity. Am I audible, ma'am?
Go ahead.
Yes, yes, please go ahead.
Okay. So today's my topic is thyrotoxicosis, which is actually rare in childhood. There are two terminologies used synonymously, thyrotoxicosis versus hyperthyroidism. Thyrotoxicosis refers to clinical picture of thyroid hormone excess, while hyperthyroidism is related to the pathology in the thyroid gland itself, leading to increased secretion and synthesis of the thyroid hormones. The differentiation is must to know as the therapies differ accordingly. And overall, thyrotoxicosis is a rare condition in children. Coming to the etiology goes as transient versus permanent, or it is with hyperthyroidism as seen in Graves' disease or a multinodular goiter, or without hyperthyroidism seen in thyroiditis or iatrogenic causes. Graves' disease is the most common etiology for thyrotoxicosis in childhood. It is autoimmune in nature, and the incidence is around 15 to 50 per 10,000, and females are affected more than males. Coming to the clinical signs, in whom to suspect thyrotoxicosis, thyroid hormone almost influences every tissue and system, and there is moderate correlation between the degree of thyroid hormone elevation and clinical signs and symptoms. So when there is a weight loss in spite of increased appetite, palpitations, poor attention or poor scholastic performance, sleep disturbances in a child, we should suspect hyperthyroidism. Apart from that, the clinical signs can be facial flushing, enlarged thyroid, tachycardia, white pulse pressure, increase in systolic blood pressure, menstrual changes, or chronic diarrheas. Coming to the examination, a thorough history and a physical examination is must, which should include the measurement of the pulse rate, blood pressure, respiratory rate, and body weight. Along with it, the local examination is a must to assess the thyroid size, tenderness, symmetry, and nodularity. And do not forget to examine the pulmonary system, cardiac system, and neuromuscular system thoroughly. And last, do check for the peripheral edema, eye signs, or the pretibial myxedema. The biochemical assessment, TSH is the only measurement which has the highest sensitivity and specificity, and it should be used as the initial screening test. There are few definitions in regard to hyperthyroidism, that is overt hyperthyroidism, where T3, T4 will be raised and TSH will be subnormal, almost less than 0.01. Then in mild hyperthyroidism, T4 levels may be normal, only T3 levels will be raised, also called as T3 toxicosis, and TSH will be obviously low. And there is an entity called as subclinical hyperthyroidism, where both T4 and T3 will be normal and only TSH will be low. And coming to the investigations related to etiology, it depends on the availability of expertise or the resources. So in a patient who is having a big thyroid, a big goiter, then and severity with the orbitopathy, the likely diagnosis is Graves' disease. While in a patient who doesn't have a definite orbitopathy, we can go for radioactive iodine uptake. So these are a few images showing in Graves' disease the uptake of technetium scan. And of course, in cases where scintigraphy is contraindicated, we can go with the ratio of T3 to T4. T3 will be elevated in hyperthyroidism, while T4 is elevated in thyrotoxicosis caused by thyroiditis. Coming to the treatment, there are only 3 modalities of treatment, that is radioactive iodine, antithyroid drugs, and surgeries. And all over the guidelines and the recent studies suggest that the best part is to start with antithyroid drugs. There are only 2 antithyroid drugs known, that is methimazole and propylthiouracil. But in children, methimazole is indicated because of the side effects. Propylthiouracil is not used. The advantages, they are best established, and there are chances of permanent remission with euthyroidism. Disadvantages are long. It takes long course, maybe from 5 years to 10 years, and there are chances of side effects, and it requires frequent visits, and compliance issues are always there. The second line of treatment is radioactive iodine. It is a permanent cure, safe, and little bit of radiation exposure is there, but studies show that it doesn't have any long-term effects. But the disadvantage is it needs a lifelong therapy with thyroxine because of the hypothyroidism present because of this treatment. And it is used as first line in age group of more than 10 years of age, and second line in low dose in the age group of 5 to 10 years, or in cases of recurrent hyperthyroidism. Surgery is the last option. It is definitive, rapid, without any theoretical risk of radiation exposure. Of course, it has its own surgical risk of hemorrhage or recurrent laryngeal nerve palsy. And it also needs lifelong replacement with T4. It is usually used as first line for large goiters, and second line in the age group of 5 to 10 years where remission doesn't occur with antithyroid drugs, and third line for failing of radioactive iodine. With this, I would like to conclude. Thank you. Thank you very much.
Thank you, Dr. Madhura, for your timely presentation. Now I would like to ask Dr. Mahesh sir to have their expert comment.
Thank you, Dr. Madhura, for revisiting, or rather visiting for the first time for most of us, because it's one topic which you left it for options along with metabolic disorders in our postgraduate days. So I was wondering how many cases of thyroid oxygen. Postgraduate, I had not seen a single one. In my practice, I must have seen about 4 cases. But I unanimously saw almost all of them with the exophthalmos. So very typical presentation, and they were coming anywhere from 6 to 8 years of age, not in the early age group. So we can generally remember that won't happen in early age. That's very important. Second, whenever you suspect the whole other clinical character, we should have a wonderful picture of that with a multiple kind of levels you need to see right from head to toe, and I will not repeat that. So that definitely gives a good, nice clinical clue to that. And once you see that, obviously you don't fail to send TSH, FT3 and FT4 all, and then correlate. So you are having TSH low and FT3, FT4 either high or normal, one of them being normal. Think of this. Wonderful that presentation, subclinical, mild and severe. I think that can categorize. But I believe once you suspect, and once you get these abnormalities, which is almost concluding the result, rest is all about the pediatric endocrinologist's job. So let's not mingle into some super specialty. What we should do is at least don't miss them out. Maybe sometimes you miss on the first visit, but subsequently you get the same tachycardic child, anxious child, exophthalmos coming up, and failure to thrive. At least give a thought. These are the conditions where we should at least suspecting time investigate, and you get a first clue. You better hand it over to the pediatric endocrinologist, because it requires a higher kind of, if I'm seeing 3 cases, he has seen about 30, 40. So he's also not kind of, but yes, he has seen 10 more experience. So that's how we should operate. These kind of rare condition, better hand it over to the specific experts so that they will look after, they decide whether surgery is required or radiotherapy is required or whatever it is. And monitoring. It's better you hand it over this patient to the specialist. That's my take on it. Thank you very much.
Thank you, sir.
Thank you very much, Mahesh sir, for your expert comment. With that, we will move on to our third speaker. She is from Thane IIP, Dr. Grivita Raikar. Dr. Grivita is going to talk on managing HIV in children. Over to you, Dr. Grivita.
Good evening, everyone. I'm Dr. Grivita Raikar from Thane. Ma'am, is my slide is visible?
Yes, we can see that.
Grivita. It's visible. Just made a slideshow mode. Yes, it's perfect.
I'm happy to share with everyone that there is a 70% reduction in the newly added HIV infected cases from the age group of 0 to 14 years, largely due to a good ART in HIV infected pregnant women. So majorly it's a vast topic, but it takes 5 minutes is too lesser time, but I would try to do justice as much as possible. The major route of transmission is vertical transmission, that is mother to child transmission. It could be either intrauterine, intrapartum or postpartum. Parental exposure to infected blood or blood products, the sexual contact. Moving on to case 1, Sia, a day 1 newborn to a mother HIV seropositive. In brief with the management, the mode of delivery can be as like any other ANC, but it has to be noted that no milking of the cord or delayed cord clamping to be done. Standard neonatal care according to the Safe Motherhood guidelines with universal safety precautions. Infants born to HIV infected mothers should receive zidovudine prophylaxis for 6 weeks. In high-risk infants, dual prophylaxis with syrup, nevirapine and zidovudine may be considered. Feeding strategies have to be discussed with the mother antenatally itself. It should be either exclusive breastfeeding or exclusive replacement feeding. No mixed feeding recommended. Points to remember: at 6 weeks in an HIV-exposed infant, start cobitromazole prophylaxis, stop zidovudine or nevirapine prophylaxis. NACO recommends DNA PCR test on dried blood test sample of an infant to detect the viral nucleic acid, check the growth, give vaccination, reinforce on the feeding option selected earlier. Test for HIV antibodies at 18 months. Case 2, Ahan, a 3-year-old male, posted for circumcision surgery on routine pre-op investigations confirmed HIV seropositive status. The diagnostic modalities could be mainly detection of the viral nuclei by DNA or RNA PCR, antibody detection. These are the main 2 ones. Antigen detection by the that is the P24 antigen, and virus isolation. Assessment of a newly diagnosed child with HIV would primarily be growth assessment, clinical assessment, which includes history and physical examination, developmental assessment, laboratory assessment, and psychosocial assessment. In physical examination, mainly we look on the clinical features pertaining to HIV per se, would be something like molluscum contagiosum or recurrent oral thrush or recurrent ear infections. Look for evidence of opportunistic infections, tuberculosis. In developmental assessment, it is very important to note on the milestones. Loss of previously attained milestones or delayed milestones could itself be an early indication of HIV encephalopathy. Moving on to the laboratory, non-availability of the test should not delay the onset of the antiretroviral therapy. Test should be based to determine the stage of the disease, identify concomitant opportunistic infections, and to determine the baseline parameters. Staging is very important to be done before the onset of ART, but mind you, ART is irrespective of the staging or the CD4 counts. Now, choice for ART regimen in children: confirm the HIV infection, treat and stabilize opportunistic infections, baseline investigations including CD4 count and counseling. If the age is less than 6 years with a body weight of less than 20 kgs, we start with abacavir plus lamivudine plus lopinavir or ritonavir. If the age is from 6 to 10 years, body weight 20 to 30 kgs, abacavir plus lamivudine plus dolutegravir. Age is more than 10 years with a body weight of more than 30 kgs, tenofovir plus lamivudine plus dolutegravir. Supportive care would include psychosocial assessment before ART, as the treatment requires long life adherence. Financial burdens needs to be discussed with the family. Healthy balanced diet, good moderate exercise and dental care, and adequate sleep. A word on HIV co-infection with tuberculosis. It is important to know that to initiate AKT treatment first, ART should be started within 2 weeks of the AKT. All HIV-exposed infants should get cotrimoxazole prophylaxis from 6 weeks of age, the dose being 5 mg per kg per day as a single dose until 18 months if negative and until 5 years if positive. Monitoring parameters include, after initiation of ART, include clinical monitoring in terms of growth, development, treatment adherence, adverse effects of the drug, immunological monitoring for the CD4 counts, viral load testing, looking for any opportunistic infections, common childhood disease, complications of HIV. And it is very important to basically refer the child to a good ART center for under the government schemes, which would not only save the cost of the patient, but also would ensure a good adherence to the medications. Thank you so much.
Thank you, Dr. Grivita. I think you have given a wonderful overview of HIV matters to the pediatrician. Again, this becomes, once it is confirmed, becomes a specialist kind of a management. I don't know how many of us are really trained and expert at managing HIV on day-to-day basis, but certainly one high index of suspicion in a case where you are stuck and not getting a diagnosis. So it may be a PUO case, it may be encephalopathy without any cause, at least have a suspect. I think most important thing is the concept related to vertical transfusion, because that's the biggest pediatric crowd that we see. Whenever mother is positive, whether to deliver by LSCS or normal, whether to give breastfeed or not, whether to vaccinate or not, are the age-old kind of controversies which are going on. And evidence definitely proves that when there is LSCS, the chances of transfusion is less. If you are giving breast milk, that increases the transfusion rate by almost 33%. But in a resource-poor countries, giving the top milk or formula feed has got a higher chances of infection and mortality. That's the reason with the safety precautions taken, we still recommend to give breast milk. As far as the vaccines are given, preferably live vaccines are delayed or not given unless and until it's proven that it's not HIV, but a killed vaccine, the inactive vaccine can be definitely given. That's what we say. As far as bigger children, I don't think we see as many from the horizontal transmission of 1-2% transmission pediatric age group. But again, I repeat, high index of suspicion. You all will agree in last 10 years, we have seen very, very few cases of HIV in clinical practice. Prior to that, it was a kind of a protocol in our hospital that every patient getting admitted, we used to do a HIV testing. And now last 5 years, we have hardly picked up any. So I'm sure it's a very welcome sign, as Dr. Grivita already said, 70% reduction in new onset cases. It may be still more. And I'm sure, I hope it will be again a disease on extinction, hopefully. So again, high index of suspicion when you don't have a definite answer, definite diagnosis, or a child falling sick again and again, suspected immunodeficiency in a bigger child, always do this test upfront. And rest, I think, is a story. I think you did a wonderful job. Thank you very much.
Thank you,
Thank you, Mohite sir. Our fourth speaker for today is Dr. Monish Boli sir. He is consultant pediatrician, neonatologist, and allergy specialist practicing since 10 years at Sholapur. He will be presenting on update on thalassemia. Yes, sir.
I'm Dr. Monish Boli. I'll be talking on thalassemia. So we all know that there are two types of thalassemia, alpha thalassemia and beta thalassemia. That depends upon the type of globin chain affected. And the phenotypical presentation depends upon the number and type of mutations. Now, earlier we used to term as thalassemia major and thalassemia intermedia. Now these terminologies have replaced with the new terminologies as transfusion-dependent thalassemia and non-transfusion-dependent thalassemia. Any child who is present between 0 to 2 years with severe anemia and requires regular transfusion are termed as transfusion-dependent. Example is thalassemia major. Their complications are transfusion-related. Non-transfusion dependent thalassemias present usually more than 2 years of age. They have moderate anemia and they don't require transfusion or require intermittent transfusion. Their complications are due to extramedullary erythropoiesis. Now, the pathophysiology of thalassemia major is there is beta chain defect leading to relative excess of alpha chains. This leads to destruction of RBC precursors and ineffective erythropoiesis. Anemia leads to pallor and fatigue, poor growth and hepatosplenomegaly, and bone marrow expansion leads to facial and skeletal deformities. Recurrent RBC transfusion lead to iron overload, leading to liver, heart, and endocrine problems. Now, thalassemia major presents between 16 to 12 months of age as progressive pallor, failure to thrive, recurrent infections. They have mild icterus, hepatosplenomegaly, hemolytic phases. They are found in high prevalence community. Now, when you suspect a case with thalassemia, we go ahead with the investigation. We do a CBC, which shows a very low hemoglobin with microscopic hypochromia anemia, and there is relatively high RBC count for HB level. And peripheral sphere will show features of hemolysis. We'll do also blood grouping and antigen typing. For quantification of hemoglobin, there are two tests, that namely HB electrophoresis, which is routinely been done, and HPLC, that is high performance liquid chromatography, is the method of choice now. Genetic testing for mutation wherever possible, and HLA typing should be done, and parents HPLC also be done. Now, the management of thalassemia, the backbone of treatment of any thalassemia child depends upon transfusion, chelation, and monitoring. Also, we need to know about what are the advances in thalassemia, and our ultimate aim as a pediatrician should be towards zero thalassemic births. Now, what to do before starting a transfusion program? Counsel the parents regarding the disease course and treatment. Process for a SBCT thalassemia card from your state blood transfusion council. Do a screening of HIV, HBsAg, and HCV. Initiate or complete hepatitis B vaccination for the patient, and enroll the patient in government schemes wherever applicable. Now, when to transfuse and when to initiate? Once the diagnosis of thalassemia major is confirmed and the patient is having HB less than 7 gram percentage on 2 occasions more than 2 weeks apart, or if the HB is more than 7 gram %, but the patient is developing facial changes and fractures, poor growth, or extramedullary erythropoiesis, we should initiate the chronic transfusion therapy. Now, optimal transfusion regimen, target the pre-transfusion hemoglobin up to 9 to 10.5 gram %. Use leukodepleted packed red blood cells with hematocrit more than 60%, not older than 2 weeks. Adequately, ABO and RH compatible blood should be used. Transfusion can be given 3 to 4 weekly at 15 ml per kg. The post-transfusion HB should not go greater than 14 gram %, and maintain patient transfusion record book. Now, chelation therapy should be started when the serum ferritin is more than 1000 microgram per liter on couple of occasions. Usually it is crosses after 10 to 20 transfusions. Our target should be to maintain the ferritin level less than 1000 microgram per liter. Monitoring of ferritin, LFT, and serum creatinine should be done every 3 to 6 monthly. And in children above 8 to 10 years, wherever required, T2 star MRI should be done annually. Now, stopping of chelation is not recommended and can be continued at very low doses if the serum ferritin is less than 500 microgram per liter. Now, we have 3 types of chelators available, that is Deferasirox, Deferiprone, and Deferoxamine. The first 2 are oral chelators, and the Deferoxamine is a IV or subcutaneous chelator. Deferoxamine is usually used in intensive chelation wherever required. And the chelator of choice is a Deferoxyrox because it is given OD dose and it has a good chelation over heart and liver. Now, supporting management in these children, we can monitor their growth and development periodically, give folic acid supplementation in small doses. Vitamin C should be given on the patients who are on Deferoxamine infusion. Other vitamins are usually not recommended, but we have to ensure optimal levels of vitamin D3. Dietary restriction is not recommended. Immunization as per schedule and annual monitoring of endocrinopathy and bone health for children above 10 years of age. So bone marrow and stem cell transplantation is the only curative treatment option available currently. The optimal age for this bone marrow transplantation is 2 to 10 years. Optimal patient status, the patient should be optimally chelated. He should have no organomegaly, no organ dysfunction. Ideal donor is a fully HLA matched sibling donor. Optional donors are matched unrelated donor, haploidentical donor from the family. The source of stem cells, bone marrow, is preferred over the peripheral stem cells. Now, these are the newer modalities available for management of transfusion-dependent thalassemia, that is thalassemia major. Luspatercept is an anti-apoptotic, prolongs RBC life. It is given subcutaneously every 3 weekly, approved for patients more than 12 years. Currently, it's not available in India. Thalidomide has been tried in few patients. It causes HbF induction and immunomodulation. It is given orally, currently being evaluated. Ruxolitinib is a JAK2 inhibitor. It is given also orally, may help in reduction of splenomegaly. Gene therapy is the newer therapy available now, but it's not available in India. Now, management of non-transfusion dependent thalassemia, example thalassemia intermedia, all the patients should undergo growth monitoring, monitoring of HB, organomegaly, iron overload, and dysmorphism. Folic acid can be given as a small doses. Hydroxyurea can be given as a therapeutic trial in all patients at 10 to 20 mg per kg per day. Intermittent transfusion is indicated in acute drop in HB secondary to some infections. Regular transfusions, if this patient requires regular transfusion, he should be referred to a hematologist. Now, prevention of thalassemia should be our ultimate goal. It can be done by carrier detection in high prevalence population, genetic counseling of couples who have already been married and are thalassemia carriers or thalassemia intermedia, and prenatal diagnosis can be done by chorionic villus sampling and amniocentesis. Now, the key messages from this presentation is HPLC, high performance liquid chromatography, is a method of choice for screening and diagnosis of thalassemia. Genetics testing to be considered in every patient, because at the moment we diagnose a thalassemic child, we should counsel the parents regarding the treatment available, that is bone marrow transplantation. So genetic testing is very important. Current terminologies that we should use is transfusion dependent thalassemia and non-transfusion dependent thalassemia. Monitoring of serum ferritin is very important when the child is started on chelation. Stem cell transplantation is a treatment of choice, and our as a pediatrician, ultimate goal should be prevention of thalassemic birth. Thank you so much.
Thank you, Dr. Monish. Now I would request Dr. Prashant Jadhav, sir, to give his expert opinion. Over to you, sir.
Yeah, thank you. I thank Dr. Monish Boli to take this topic in such a short time. He has covered it very well and very nicely, and almost all the major important points have been covered. As he rightly said, the aim and emphasis should be on prevention, and it is one of the known genetically hereditary and always all well-studied disease, but still so common that almost each and every town and city even in our state of Maharashtra is having a thalassemia society, and that itself speaks about the abundant number of patients that are there. Once the patient is diagnosed, yes, of course, we have to see whether he is a transfusion dependent or non-dependent, and accordingly the treatment and line of management can be considered. The transfusion should be as minimum as possible, but at the same time without compromising the quality of the patient. Chelation adequately is really very, very important, and iron overload has to be kept in mind all the time. And nowadays, even the fresh RBCs and very lot of improvement in the blood banks are there. That is all going to help us. I thank the Maharashtra IIP for taking this topic here for discussion, because what personally I feel is that we need to create more and more awareness amongst all the pediatricians in Maharashtra, so that we create awareness in the society that how the inheritance is there, and it can very well be prevented by either antenatal or premarital screening of the families, maybe by HPLC or genetic testing, which can be done at low cost as compared to the cost that the child or a family has to go. And nowadays, more and more families, with the advancement of bone marrow transplant and stem cell, everyone wants a magic cure, but it is not easily available, and it's really very, very expensive. So let us all pledge and focus on prevention of thalassemia, and that will be, I think, the most important take home from today's topic. I thank again Dr. Monish for taking this topic very well.
Thank you.
Thank you.
Thank you, Prashant, sir, for your expert opinion and also pointing out on the awareness of thalassemia. Now I would like to introduce our second speaker, Dr. Parikshit Devare, practicing pediatrician since 11 years. He was treasurer and secretary of IIP Dhule at 2008 and 12. At present, he is assistant professor, ACPM Medical College Dhule. He will present on mobile deactivation. Over to you, Dr. Parikshit.
Hello, am I audible now?
Yes, you are audible. Please.
So the today's topic of discussion from my side is mobile phone de-addiction. So actually we should know is mobile phone really an addiction, or it's just a myth that people are saying why is using mobile phone, why is using mobile phone. So to describe any addiction, there has to be some criteria. So about 86% of people who are using mobile phone, they daily check their mobile phones when they are with their friends and with their family. Out of this, 64% of the teens or 62% of parents, they use their mobile phone as soon as they wake up in the morning. According to Chambray et al., the cell phones are possibly the biggest non-drug addiction of 21st century. So it was Mark D. Griffith, he is an English psychologist. He described mobile addiction as technological addiction involving human machines and interaction. In 2016, in the Frontiers of Psychiatry, they suggested DSM-5 criteria for compulsive gambling and substance abuse, which they utilize for smartphone addiction. So the criteria of this were salience, mood modification, tolerance, withdrawal symptoms, conflict, and relapse. So if a child is using mobile phone, we have to see whether he is satisfying these criteria. Salience is like the smartphone becomes a very important activity in the person's life and it dominates the behavior, the feelings, the behavior. Mood modification, the child gets a tranquilizing effect on using the mobile phone. Tolerance, here the concept of dopamine loop comes in. Here the child needs more and more amount of mobile phone so as to get that dopamine high. Withdrawal symptoms, if you take a mobile from that child, he gets withdrawal symptoms, shakes, moodiness, irritability. Conflict, there is an interpersonal conflict with social life, hobbies, interest. Relapse, excessive use of smartphones, sometimes it goes on and again the child starts using the smartphones. So if it's satisfying this criteria, that is why we are calling the smartphone addiction a addiction. There's a new concept nowadays called nomophobia, no mobile phone phobia. It is a phobia in which if a mobile phone is taken from some person, the person starts getting anxiety, respiratory alertations, trembling, respiration, disorientation, tachycardia. It's a very difficult condition to treat on. So, by definition, mobile phone addiction is a chronic and periodic obsession caused by repeated use of mobile phones, which may lead to intense and sustained demand and reliance. So, what are the main causes actually of smartphone addiction? The smartphone addiction is not a smartphone addiction per se. It's the addiction of internet, because the internet which is present in the smartphones, which comes with 4G and 5G speed nowadays, people are becoming addicted to that. The functionalities of smartphones are increasing day by day. Wide ranges of advanced smartphones are coming in the market. Gaming, the games which were played initially on TV, now they are played on mobile phones. So child are getting addicted to these games very frequently. So how do you acknowledge that the child is having a smartphone addiction? First of all, we should look for the amount of the kind of hours the child spends on the mobile phone. It is similar to kind of high which a drug addict or an alcoholic gets. The child gets the same high on using the smartphones. The more the number of hours he uses smartphones, the more better he feels. He is having lack of interest in other activities. All his leisurely activities, homework, schoolwork, he is not interested. If we take the smartphone from the child becomes irritable. Desperation of panic attacks comes, he becomes very anxious. So these are the things we should consider. We should acknowledge that your child is going into a smartphone addiction. So how do you tackle with these conditions? There are very simple remedies which can be utilized in day-to-day basis. Here per se, there is no medical treatment for the smartphone addiction nowadays. So what we have to do is we have to control it at home itself. So we have to educate the children about the ill effects of smartphone in a very simple language so that they can understand. Fatigue, headache, loss of sleep, memory loss, ringing ears, joint pains. We have to set screen time for children. It is recommended that less than 18 months of kids should not be exposed to screen at all. 18 to 24 months, they should be given exposure only with parental supervision, that too with high quality kids program. 2 to 5 years of age, only an hour per day, and more than 6 years of age, the school allows the smartphones. So we have to take care that the child is not losing his healthy habits. So we have to make digital free zones at home. So make a small room in your house like balcony or a dining room where not a single electronic device is held. Not even the parents or the kids should be allowed to take any kind of electric device in that room. We just make your discussions, do some activities in that zone. Encourage your child to do lots of physical activities. Encourage them to play outdoor games, badminton, football, cricket, running, jogging. Media fast. So, like we do fast in our day-to-day life, we have to do fasting for the media devices nowadays. So select one day in a week on which day not a single mobile device is utilized in the family. Even the parents are not using, the kids are not using, no laptop, apart from some emergency calls. So we have to keep in mind this media fast. Break time. Whenever the child is using smartphone for the school activities or all, we should take care that every 30 minutes the child is taking some break and is stretching and doing some mini strolls. Maintain a strict smartphone schedule. No smartphones during the meal time, no smartphones before sleep. At least 1 hour before sleep, the child should be away from the smartphone. And even if the child is giving some unreasonable demand, you should not satisfy those demands. Bond with your child. Encourage the child in playing some board games, cleaning, cooking, gardening. Inculcate the habit of reading, playing instruments, painting, and make your weekends very wonderful by playing, swimming, watching movies, so that the kids are very happy learning these things. Smartphone is a thing which cannot be like 100% restricted. So when a child is using a smartphone, we have to actively supervise the child. What is his posture like? What is the screen brightness? At what distance the child is seeing the mobile phone? Here's a rule of 20-20-20, which helps in reducing the computer vision syndrome. So after a amount of time the child has spent on smartphone, we should give a 20 minutes break. Take a break for 20 seconds and then look at an object which is 20 feet away from him, so that this will reduce the computer vision syndrome. Set passwords on your mobile phone. But nowadays kids are so smart that they can hack our passwords also. So we have to keep on frequently changing the passwords. Be a great role model. So in spite of like watching mobile phones in front of them, you should yourself read some books, do some physical activities, so that the child learns the same thing from your parents. So ourselves being role model is very important in this. Yes day. So this concept is very important. Nowadays, all parents are like saying no to kids for everything. I want to go to a movie, no. I want to watch this, no. I want to do this, no. So make sure that you make one day in your life as yes day. So during that day, you should not use mobile phones at all, and you should listen to all your demands, all the demands of your child. So as they become happy and you also feel good giving quality time to your kids. There's a very beautiful movie on Netflix called Yes Day. I recommend everybody to see this movie. So when to refer a child to a child psychologist? So instead of doing all these activities, all those things, trying to control the smartphone, the child is still spending more hours on smartphones. He's becoming irritable and frequently throwing tantrums. He's getting refractory errors. His mind is constantly preoccupied with these social media, games and apps. And this is hampering his scholastic performance. This is a time at this where the child should be referred to a proper psychologist. So we have to re-establish the human-human interaction, face-to-face connection. So we need to limit our mobile phone rather than banning it, because we cannot ignore the force of technological advancement. And are we still missing this age-old phone which we used to use in our childhoods? This was the last slide. Thank you.
Thank you, Parikshit sir, for a wonderful presentation. Now I would request our expert, Dr. Prashant sir, to give his opinion. Over to you, sir.
Yeah, thank you. Dr. Parikshit, really very nice way of taking up this new topic, which is really a mobile de-addiction. Well, it has become one of the latest and dreaded addiction, and which needs a lot of awareness in the society. Most of the points as far as the school-going children or adolescents are concerned that you have definitely covered. Well, a few points I would like to add is that this addiction is not there only in the grown-up children, even the smaller children, even the pre-primary or the primary going school children are also having the signs and symptoms that you mentioned about the salience, tolerance, conflict, and withdrawal symptoms that we can see even in that. And yes, the adults are mostly responsible for that. We must be seeing whenever we take rounds in the hospital, a child 9-month-old, 12-month-old, 15-month-old is admitted for gastroenteritis, is also sitting in the mother's lap with the mobile or a tab in the hand. This is what is happening in the society. So, dear friend, let us acknowledge that there is a tsunami of overuse of screen. I won't say only mobile, but a tsunami of overuse of screen. And that's why we are seeing a lot of cases of autism, ADHD these days. So all this awareness is really important, and creating awareness about it is going to be the sole key. And as Parikshit has pointed out, acknowledging the issue. Many a times if the parents are coming with these complaints, it's already late. So we as pediatricians, I think now a time has come that we should have some awareness pamphlets written in our OPDs or in our waiting room to create about when it should be started. Because if a family is showing the screen or mobile to a child who is less than 24 months of age, I think it's our failure. We need to create that awareness. When the children are coming for vaccination, let us create that awareness, and that's what will be a prevention of this mobile addiction, and the chances of requiring de-addiction will be less. That's it I want to say.
Thank you, Prashant sir. Now we will move forward with our last speaker, Dr. Muzammil Koshir. He is Assistant Professor SVN GMC Yavatmal. He is pediatrician and neonatologist at New Cotton City Hospital, Yavatmal. His topic for today is migraine, a headache for pediatrician. Over to you, sir.
Thank you, ma'am, for the introduction. Good evening, everyone. Just a second. Good evening, everyone. My topic for today is migraine, headache for the pediatrician. As everyone knows, migraine itself is a benign disease, but why it is important in our day-to-day practices is that headache is one of the most common cause of presentation in our OPD, and it is also one of the most common cause for school absenteeism, poor academic performance, and as well as parental anxiety. So moving directly to the migraine, let's first classify headache. Headache is classified in three different categories. Primary headache, like migraine, tension, cluster headache. Secondary headache, where there is some underlying organic cause like infection, trauma, intracranial hemorrhage, tumor, raised ICT, and cranial neuropathies like trigeminal neuralgia. What is migraine? Migraine is an episodic, periodic, paroxysmal attack of moderate to severe throbbing pain separated by pain-free intervals. It is always associated with nausea, vomiting, photophobia, abdominal pain, and desire to sleep, and motion sickness sometimes. And family history is present in 70 to 90% of cases. According to International Classification of Headache Disorder, third edition, migraine is classified into migraine without aura and migraine with aura. This is the diagnostic criteria which was given for diagnosis of migraine without aura as well as migraine with aura. These are some childhood periodic symptoms which are precursor to the migraine, are very important for the early detection in the patient who will be landing into migraine, like cyclical vomiting syndrome, abdominal migraine, which again is a very important differential diagnosis in patients with recurrent abdominal pain. Then third one is benign paroxysmal vertigo of childhood. Now coming to headache, whenever a patient of headache comes to our OPD, the most important thing is detailed history taking. These are some points which we should cover in the history, like headache characteristic, its severity, its site, its duration, and its referral. And the second point is trigger factors like caffeine, cold water, stress, deprivation of sleep, starvation. There are certain warning symptoms which we should ask, which will guide us to the secondary causes of the headache. Then symptoms during attack, like associated symptoms, whether there are vomiting, there is abdominal pain, tinnitus, other etc. Relieving factors, how the headache is relieved by sleep or by taking medication, and the symptoms between the attack, which is again very important because if the symptoms are continuously present, then we can suspect that there is something organic cause going in the brain. Then family history is very important because it is positive in 70 to 90% cases of migraine. After taking a detailed history, we can classify migraine into 4 different patterns. That is, headache into 4 different patterns. That is acute headache, which can be seen in infections, upper respiratory tract infection and meningitis. Acute recurrent headache, which is again characteristic of migraine, tension headache, cluster headache. Chronic progressive headache, which is usually seen in case of intracranial tumors. And chronic non-progressive headache, which can be due to some drug abuse, or again it can be due to migraine. From the detailed history and examination, we can get certain clues which will guide us to the secondary causes of headache. As we all know that migraine is a clinical diagnosis and it is a benign disease. But what is more important is to diagnose something, some organic cause which is causing headache. So these are the few clues. Like if there is fever, then we can suspect upper respiratory tract infection, systemic infection. If there is weight loss, then it can be malignancy, tuberculosis. If neck rigidity is present, then it can be due to meningitis. If the BP is raised, then we can suspect a renal or adrenal cause. And if injuries are present, then it can be secondary to trauma. These are the red flag signs which we should be very cautious in OPD whenever a patient of headache comes to you, because these are definitely suggesting us a secondary cause like systemic signs and symptoms of fever, organomegaly, rash. We can suspect some viral cause. Neurologic signs and symptoms like if there is change in speech, there is loss of memory, there is weakness, motor weakness, or the pupil reactions are asymmetrical, then it may suggest some intracranial pathology. If there is sudden onset of the headache, if there is occipital location is very important because it suggests us that something is going on in the posterior fossa. If there is some change in the character of headache, which was previously a moderate, now it has become severe, or it was a throbbing, now it has become some other character, acquired some other character, or if the age is less than 6 years. When to perform neuroimaging? Usually migraine is a clinical diagnosis. We do not require any neuroimaging to diagnose it, but if we suspect, if the age of presentation is less than 6 years, or if there is any abnormal neurological examination of finding, if the pattern is chronic progressive, or if the family wants, then we can go ahead with the neuroimaging. We have two options, MRI versus CT. Most of these studies suggest that MRI is better than CT because we have a better vascular differential diagnosis. And EEG is usually not required in migraine. Only if there is association of seizures, we can go ahead with EEG. Coming to the management of migraine, we have non-pharmacological method, pharmacological method, and preventive methods of prophylaxis. Non-pharmacological methods include headache education. We usually advise to the parent or the patient himself that they should maintain a diary and should write about the duration and about the characteristic of the headache. Then second is lifestyle modification, which is the most important part in management of the migraine. It includes sleep. One should get adequate and complete sleep, adequate meals, proper aerobic activities, relaxation, and avoidance of the trigger factors. Then there is complementary therapy, which is biofeedback therapy, which includes relaxation techniques, hypnosis, acupuncture, and massage therapy. Then coming to pharmacologic treatment, this is required. The pharmacologic treatment should be initiated within first 2 to 3 hours. Then only it is effective. Otherwise, there is not much role. The drugs which are preferred are NSAIDs, acetaminophen, ibuprofen, and naproxen. If there is no response to the NSAIDs, then we can go ahead with triptans like rizatriptan, which is indicated, which can be used in children about 12 years of age, and elmotriptan, which can be used in children 6 to 12 years of age, and it is approved by US FDA. Coming to the prophylaxis for migraine, which is usually not required in pediatric patients. Still, if there are attacks more than 2 to 4 times per month, disability for more than 3 days per month, duration of attack is more than 48 hours, or the acute medications, the medication used for acute attack are ineffective, contraindicated, or overused, or the attacks produce prolonged aura or true membranous infarction, or for the patient preference. What is the ideal duration of the prophylactic therapy? There is no fixed duration, but our aim is to achieve 4 to 6 months of symptom-free period. After that, we can taper the drugs. What are the drugs which can be used for preventive therapy? They are beta blockers like propanol, antihistaminic, ciprofloxacin, anticonvulsant, topiramate, valproic acid, and calcium channel blocker like flunarizine. The choice of the drug depend upon the comorbid condition associated. Like if there is some allergic condition, we can go ahead with antihistaminic. If there are convulsions, seizures along with migraine, then we can go for topiramate. If the patient is obese, valproic acid if the patient is thin. Then again, we can use aminotriptyline in case patients with some depressive disorder. Coming to the last slide, key messages. The most important part of in migraine or the patient with headache is the detailed history and clinical examination. And again and again, I am stressing that migraine is a clinical diagnosis. We should be very able to identify the red flag signs, which will divert our diagnosis to the secondary causes. Neuroimaging is only required in suspected secondary headache, and lifestyle modification is an important part of management. Thank you.
Thank you, Dr. Muzammil. A well-detailed presentation on migraine. Now I would request Dr. Prashant sir. Over to you.
Thank you. Thank you, Dr. Muzammil. It was a very nice presentation, and the topic is a migraine, a headache to a pediatrician. If we really follow whatever you have said, especially the last slide, I think a pediatrician can diagnose a headache without having any headache to himself or herself. Here, I remember our great teacher, Dr. Y.K. Amdekar sir said, he always says that whenever you have a doubt, you should take a history in detail, and you should take a history like a UG student. So as Dr. Muzammil rightly said, it's a clinical diagnosis. So we should go have a detailed history, family history, the pattern of what is the headache, whether we want to differentiate it from the secondary causes of headache. So definitely a history taking and clinical examination is going to be there. It is a diagnosis of exclusion when you are excluding the secondary causes of headache, but it doesn't mean that you rule out others by investigating. So emphasis I would give is that it's a clinical diagnosis, should be done on the basis of proper history taking, clinical examination, and an examination to rule out the secondary causes of headache, whatever have been mentioned. The incidence of headache as such or migraine is definitely increasing with day by day modification of lifestyle, and children and adolescents are now following to a great extent the lifestyle of an adult, sleeping late, watching a lot of TV, computer, the spicy food, and all these predisposing factors. So history taking, predisposing factors, and yes, as far as the treatment is concerned, non-pharmacological methods should be implemented first before going in for the uses of medicine, and prevention definitely would be required in severe cases. And sometimes we have to differentiate them from cluster headaches, and again that would be done on the basis of history itself. And headache is again the second commonest complaint by the children after pain in abdomen. So one of the reason could be a functional, that again has to be differentiated on our clinical and giving patients to the history taking. That's what the message that I want to give.
Thank you so much, Prashant sir. Now I would hand over to Dr. Reena Rathi. Over to you, ma'am.
Thank you, Neha. Thank you very much. With timely presentation and expert guidance, we are coming towards the end of our session. Is there any question answer, or just we are checking on the chat box?
No, I cannot see any questions.
No question in chat box, but anyone wants to ask some question can raise the hand. Excellent presentation by all the speakers and the guidance given by our experts. Both experts were up to the point and very well oriented to the topic. Thank you very much, our expert. Now we are coming towards the end of our session. That is a vote of thanks. I sincerely thanks my audience, joined through the Zoom link and also with the YouTube link. Without your special appearance, it is very hard to conduct the program. My sincere thanks to our MNC observer, Dr. Shirish Deshpande sir, for your valuable time. I would like to thank our President Hemant sir, our Secretary Dr. Amol Pawar sir, Chairperson of the Maharashtra IIP Women's Wing, Dr. Renu ma'am, Co-Chairperson Dr. Sonali ma'am. We sincerely thank you for giving us such a wonderful sessions with the name of Tuesday Talks. And it's really unique and very useful to all the pediatricians. With that, I thank my expert for today's session, Dr. Mahesh Mohite sir, Dr. Prashant Jadhav sir. Without your guidance and expert advice, this last talk of this year will not be that much successful. I would sincerely thank my co-moderator, Dr. Neha Singh, and also I would like to congratulate her for becoming co-chairperson for our next year. Congratulations, Neha. I would like to thank, last but not the least, Pallavi ma'am for conducting our Zoom meet so efficiently and providing us a link and all the platforms very efficiently. Thank you, Pallavi ma'am. With that, I would like to say we will end this session.
Gangole sir.
Dr. Amol, anything
Gangole.
also to add?
Gangole sir, may want to talk. Gangole sir.
Amen.
Sir, bola sir. Sir, bola.
Yes, thank you very much, each one and all, for all the support throughout the year, as well as I mentioned the names in at the start of the session itself. Wonderful work done by my everyone committee, Dr. Renu, Dr. Sonali, Dr. Neha Singh, and Vishal Raut for all that flyers, Pallavi madam, everything. And it was really actually this program was crystallized when we had a talk with Dr. Subbu sir. And because we had 4 minutes talk at Amravati when I was one of the speakers or speaking on the protocol, DNR protocol. So that 4 minutes just related. And once we started this year, just Dr. contacted and then thought we let us start on this program. So I said it should be 4 minutes. So then it came to 6 minutes, and then it came to 5 minutes. Ultimately, it got settled 5 minutes. But wonderful things, 66 speakers throughout the 11 episodes, and almost 66 branches, all from all zones, and really all 66 different ones, all young talents, as already said by Dr. Mahesh Moitti sir, the finds of the Maharashtra state, and really we had a good things over this episode throughout this year. And I would really like to thank each and every Maha-APN of this Maharashtra state, as well as each and every branch, all office bearers of all branches. Whenever we communicated, they responded very well, and it was really fantastic to work throughout this year. And we witnessed this all things at Mahapedicon at Nashik also, and we had a good event at Jallos, and at Jallos event, which was at Jalgaon for last 3 days of sports. All 2 days I was there, and really it has given a once again one of the platform to all pediatricians to get together, and really that will increase the togetherness of all Maha-APs across the state. And I saw the wonderful blend of seniors and juniors at Jalgaon IAP branch, all well communicated, and everyone was enjoying the things. So that was the second Maha-AP sports, and we will witness Maha-AP sports also next year. And so I think so, we with this everything get motivated to this, and I really thank each Maha-AP once again, because the theme at the start of the year, which I projected as a share the vision, and almost in my first presidential action plan, almost all these things were narrated, and almost I think so I covered almost 80 to 85% what was stated in the presidential action plan. And for that, it is not an individual one, but it's a teamwork. And I had excellent as right hand as Amur Pawar, as always I said in my this, and left hand as Jay Kumar, and also my Vice President Dr. Vinay Patil, as well as Treasurer Dr. Mohan, and the Women Committee. Really, they came out very well, and it was, I remember those first 1 month when everything was going on. That was which name to give, but ultimately we comment. I don't want to say that, but ultimately we came to the Maha-AP Women Committee, which will work for Maha-AP, and all the things went around very well. So probably all the best wishes for next year also. And I think so, it's good to see that Dr. Neha Singh has been promoted as co-chairperson for the next Maha-AP Women Committee. I do not know about others, but she has got promoted as a co-chairperson, as well as Dr. Sonali as a chairperson. I am sure with these two ladies working from the front, they will be doing the wonderful work, and almost zonal members of all 5 zones, they also contributed well, because I think searching the talent, searching the speakers and convincing them and to speak for 5 minutes, making the PPTs is a tremendous job. It's a really tremendous job. It's not an easy task to do, but these all women have done wonderful work. So I really thank them, and I really thank my home branch, IAP Raigad, Dr. Dabadkar sir, Dr. Mahesh Moitti sir, Dr. all the teams from the IAP Raigad to give me the chance to serve as a Maha-AP president for this year. And So I really enjoyed this whole year of activities going around, and probably it will go on. And also I would just like to say, we have updated our MahaIP website. It's a dynamic one. Everything is there. All the episodes, all the what it was done are available on YouTube. Almost 475 or 480 such videos are present on the MahaIP YouTube channel, as well as 300 videos of Dr. Hemant Joshi about nursing care is also available on the YouTube channel. So I will request everybody to subscribe YouTube channel. And we have web app also. Those who are uncomfortable to open their laptop and see the MahaIP website, they can go to Maha app web also. That is a web app of MahaIP. Everything is there on that, and all information, even parental guidelines. I would like to thank all the things. Guidelines, almost 60 we have translated from English to Marathi, which was done in the 2021 year by Dr. Piyush Gupta, and is all translation done under the this guidance of Dr. Nani Odekar and his team, whole team of who are doing the Marathi translation. All 60 are there on this, and it will go on because we are having 105 guidelines on the of the IP website, parental guidelines. All will be translated, and we are doing that work also. And we did social activity also. That also is available. Dr. Vicharuka from February to, and for that I would like to thank Dr. Dabarkar sir also for carrying out this, and this is also available on the MahaIP YouTube channel. So please subscribe MahaIP YouTube channel. And also, I think so by the end of year, one more thing we will start. Dr. Vishal and Dr. Neha are working on it. Probably we will start MahaIP Instagram also. So there where the photos and this will be uploaded of the recent events. So that is the gift from of Instagram for the next year from Vishal and Dr. Vishal and Dr. Neha, and also, and of course, Dr. Amol is there because he was secretary for 2 years. So next year also he will be doing the fantastic work. I'm sure he will be after all of us to do all this work. And let us hope for the good for MahaIP. Only one thing, as a MahaIP, we should be united. We should strong, united. Still we have the problems in that, but we will try to be united and work for the children. With that, thank you everyone. Thank you very much.
Thank you.
We
sir.
also welcome
Thank you very
Dr.
much.
Girish Charde sir from Nagpur. Sir, Charde sir. Unmute kara sir, unmute.
Hi to everyone. Before Dr. Girish sir speaks, and please excuse me if I forgot any name to be specific, anything to be mentioned, but at the heart or are there in my memories and will remain in my memories. Yes, Dr. Girish sir, please. So welcome to this session, Dr. Girish sir.
Yeah, thank you, sir, for giving me opportunity to interact with everyone. Indeed, a great job by Team MahaIP under the leadership of Dr. Hemant Gangulia sir and Amol Pawar sir, and each and every member of MahaIP EB member. I must congratulate the organizers and the scientific committee members. They have planned very well all the activities throughout the year. And I congratulate and my best wishes to everyone for this platform. They are providing us to express and have a knowledgeable contribution by everyone. Thank you very much. Thanks a lot.
Thank you, sir, and all the best for your next year EB membership at CIP 2020.
Thank you. We'll work together. Thank you, sir.
Thank you. Thank you, Girish sir. I just congratulate our team MahaIP for a wonderful year. Hemant sir, it was just a memorable year with full of activities and all variety of activities. And cherry on cake is done by MahaIP Jalgaon, the Jallosh. Definitely Jalloshne सगळ्यांमध्ये जल्लोष भरलेला होता. It was wonderful 2 days. Okay, thank you everyone.
I welcome Dr. Jayant Pandrikar sir also for to speak some few lines about this thing this year. Jayant sir, video on होता थोडा वेळ करा पटकन on परत. Jayant sir, Jayant Pandrikar sir.
Hello. Thank you, Dr. Amol. Thank you very much. At the outset, let me congratulate the Maharashtra IP team led by Dr. Gangulia sir, and of course, evergreen Dr. Amol Pawar, who is the team, the whole team has worked really wonderful, wonderful, excellent. All the what you call it, whether it's women's wing, whether it is a Dr. Picharu team, or whether it is a guidelines team, all the teams worked superb, and I must congratulate Maharashtra IP 2022 for the excellent work, and they have taken this Maharashtra IP to further new heights. And definitely new team led by Dr. Ramakant Patil sir, of course Dr. Amoli is there, is going to will have to work even more than this to take it to further more heights. So once again, congratulations to Monming and the Maharashtra IP team 2022. Thank you, Dr. Amol.
Thank you, Jayan sir. With the best wishes to the upcoming team, with leading by Dr. Sonali ma'am and Neha Singh
Dr.
ma'am.
Sanjay Deshmukh sir.
Good evening to all. It's a great pleasure to meet you all again on this platform. And I congratulate Dr. Hemant Gangulia sir, the team, Amol, Dr. Jay Vandakar, the women's wing. It was fantastic year for all of us also. As an executive board member, we worked together to implement all the action plans through Hemant sir, Amol. And I'm very happy. There was so much meticulous planning and coordination by the team. So Maharashtra is most successful to implement all the action plans. We have never refused any action plan. So it's hats off to the meticulous planning by Gangulia sir, Amol, team MahaIP. When our year start, sir is after us. These are the modules we got, NTP, ECD, and they are after everybody. And that's a teamwork, definitely. And sir has set the platform. So the best wishes to Ramakant sir for the next year with all new executive board members for the MahaIP. Hemant sir, thank you for your cooperation and guiding us. We are a part of your team. It was just not an academic, but all the things you supported. And it's not a junior senior. Sir is always there. He's ever smiling again. He used to send all the details in advance. That is way of perfection. अभी भी पिछले हफ्ते सर का फोन संजय, these are the few modules is awaiting for your region. What should be done? I told sir, this is a December month. No, you should take the relaxation. But still he'll call. No, we have to submit the details. So sir, thank you very much. And sir has got excellent Sarthi, Amol. So Amol, Neha, Sonali, really, you have blessed the team. So that's a teamwork, and you're fortunate, sir. And we are also fortunate that we work under you. So best wishes, sir, for your all future tenures. And thank you very much. Thank you.
Thank you, Sanjay. Thank you, Sanjay.
Thank you, sir. Thank you very much.
I'm really fortunate to have an excellent team with me. खरं सांगायला पहिले 2 महिने जरा सर्व गोष्टी ठेवायला वेळ लागला, पण नंतर ते 2 महिन्यानंतर कसं ते सिस्टीम ऑटो मोड वरती गेलं मला कळालंच नाही. एव्हरीथिंग ऑटो मोड, ऑटो पायलट मोड वरती गेलं आणि एव्हरीथिंग बराबर गोष्टी. एव्हरीबडी अंडरस्टूड व्हॉट इज देअर जॉब अँड व्हॉट इज द रेस्पॉन्सिबिलिटी. काहीच करावं लागलं नाही. थँक्यू डॉक्टर संजय.
Thank you all speakers.
Excellent.
Sonali madam bola.
Yes, excellent guidance by Amol sir and Gangulia sir throughout the year, as well as Renu madam. Thank you very much for you all three, as well as Neha worked very hard. Pallavi madam, Vishal sir, all helped very much. Thank you very much for the guidance as well as the opportunity given for the year 23. Thank you very much. Welcome Dr. Sanjay sir and Dr. Girish sir.
Thank you, Sonali ma'am.
कोणाला बोलायचं अजून? नेहा.
Renu madam and Neha.
Yeah,
Renu madam
I
bola.
think this now it is a very different moment at this stage. I like to congratulate Dr. Sonali Shirbate, who is the upcoming chairperson for the Women's Committee 2023, and Dr. Neha Singh as a co-chairperson. And also they will perform in a great way for 2023. I know it from the bottom of my heart. And it was a very encouraging and supportive this thing by Dr. Gangolia ji and Dr. Amol, always giving me ideas and telling me that, okay, you carry forward along with Sonali. And whenever we used to, even before coming to, let me share one thing, before coming to Mahapedicon, that time there was pneumonia week and that newborn week, adolescent week. तो सर ने हमको काम लगा दिया था, नहीं नहीं मैडम पहले वो सब कर लो और फिर महापेडिकॉन को जाना, सब कमिटीज बना दो. So even in that Mahapedicon, we were releasing so many videos and so many useful things for the general pediatricians as well as society. So hats off to the commitment to Dr. Gangolia and Dr. Amol Pawar. With your help, we are now in a disciplinary action mode. So we will also carry it forward, everyone, as we have learned from you. Thank you so much for giving us the opportunity.
Dr. Grivita also wants to speak something.
Before Grivita speaks, बात निकली है. So I would like to thank IIP Thane branch also, medical engineering, बढ़िया Dr. Ram Gopal ने करवाया था. Also मला माहित नाही IIP पालघरचे कोण आहेत. The Maha IIP nursing stations, which was almost for 15 days going on. So that was a tremendous job done by IIP Palghar branch. So many, and also at the same time, मला माहित नाही जळगावचे कोण आहेत की नाही, पण डॉक्टर अविनाश त्यांनी हिना मॉड्यूल जे बनवलं, छानच हिना मॉड्यूल बनवला. बऱ्याच गोष्टी काय सांगायच्या आहेत, पण आपल्याला वेळ पण कमी आहे. जसं मनात माझं आलं तसं मी बोलत गेलोय. पण yes, Dr. Grivita.
Sir, excellent academics this year. I mean, it was one of the best years, I think, in the history of Maha IIP. Excellent learning, जे तुम्ही modules केले हे, and a very active women's wing as well. So best wishes to the upcoming team and heartiest congratulations to you all.
Thank you.
Reena madam and Neha, congratulations first, because first time timely Tuesday text is there this session.
Yes.
Very hard work by both of them. Congratulations to Reena and Neha.
I have a take on word on this. I really appreciate जसं तुम्ही काल evening ला you took the mock drill आणि हे म्हणजे it was very systematic and very well prepared. So thank you so much. Very encouraging.
सोनाली तुम्ही बोललात कारण टाइम मॅनेजमेंट आहे ना, कारण डॉक्टर रीना इज अ चेस विनर.
अच्छा. रीना मॅडम नेक्स्ट वेळा आपण दोघं चेस खेळू, यावेळेला नाही आली मी.
नेक्स्ट नक्कीच मजा येईल.
चॅलेंज करताय, चॅलेंज.
चेस पण ऑनलाईन कॉम्पिटिशन घेऊ ना दोन्हीची आपण.
हा ऑनलाईन घेऊया.
अमरावती हॅज कंडक्टेड इट 2 years.
अमरावतीमध्ये मी विनर होती मॅडम चेसची.
पण रीना नव्हती ना तिथं.
एक्झॅक्टली.
Chalo, with that, can we conclude our meet?
Yeah.
Okay, thank you everyone for our esteemed guests and our chairperson, secretary, WW wing chairperson, Renu ma'am, Sonali ma'am, Hemant sir, Amol sir, with your expert guidance and support. Definitely this Tuesday Techs had become a huge success. With that, I will like to conclude this meet. Good night and Happy New Year to all of you in advance. Thank you.
Yes. Good night, Reena. Very nice. And also Neha.
Thank you very much.
1 जानेवारीला भेटू. रेणू मॅडम 1 जानेवारीला भेटू.
Installation ठेवूया.